There's a statistic that pharmaceutical companies don't like to have bandied around. It's called number needed to treat. It's jargon, but what it means is there's never been a drug invented that works in 100% of people. Sometimes it's 7, sometimes it's 10, sometimes it's 20, or more people have to be treated for one person to benefit. And that's a bit scary if the drug that you're on is life-saving. Like, for example, a medication to prevent a blood clot in the heart after you've had an artery unblocked. The good news is, though, that there's a revolution going on in laboratories around the world, explaining at least part of the reason why drugs work in some people and not in others. And the reason is in your genes.
This is an area that's called pharmacogenomics, in which we're understanding how the individual patient's genome affects how they respond to medications, and then based on that knowledge, we can prescribe medications more smartly to individual patients.
When someone's had a blocked artery in the heart opened up, they often have a stent put in, a little cylinder of metal to keep it open. The trouble is that the stent can clot, at least early on, which is why the person is put on a drug called clopidogrel for a period of time.
That's right. Clopidogrel, usually along with aspirin, is given in people who have heart conditions, particularly those who have had or are at risk for myocardial infarction. Although most people respond pretty well to clopidogrel, there are a subset of individuals that don't respond very well, and indeed there is a certain variation in the genome of up to a third to a half of people that will render them less likely to respond to clopidogrel.
With dangerous implications.
The patient can have another heart attack even after the stent is placed. And if one were to know about this non-responsiveness, an alternative medication that might be more effective could be prescribed. So our work, as well as the work of a number of groups throughout the world, have identified a single variation in the human genome. It's in a gene called CYP2C19.
This gene, when it's mutated, stops clopidogrel from being switched on in the liver. And that means that clopidogrel doesn't do its job of making blood clotting platelets less sticky.
That's right. Clopidogrel in pill form is not active. It doesn't do much for platelets. But when it's activated in the liver, it can then inhibit how platelets clump together. And as I mentioned, people who have these variations in this enzyme cannot activate clopidogrel properly.
What then is the practical implication for the patient or the person receiving this? What should they be asking their doctor?
If a physician or his patient knows about that genetic variation, it's possible that an alternative drug can be used.
Can you test for this mutation?
You can test for it. It's a simple blood test that can be done. Then the genetic variation can then be measured more or less in a test tube.
So do you think this is duty and standard of care now, that if a cardiologist is going to prescribe clopidogrel, they should be doing the gene test?
It takes a little while for this to catch on in the general medical population, and so I wouldn't say it's the standard of care yet, but over time we believe it will become a new standard of care.
At the moment, what's done, but not often, is testing of the platelets themselves, these important little cells which are so crucial to blood clotting. The problem is, the investigations of platelets are hard to do and very hard for the pathologist to really know what's going on, hence the value of a simple gene test. The big question, though, is, with the hundreds of thousands of people on clopidogrel, could we as a nation really afford each of them to have a gene test?
Well, it's an interesting question. You know, we don't know yet how cost-effective genetic testing will actually be. It seems that it might be intuitive that genetic testing and then prescribing a medication that will work better or prevent side effects would be cost-effective, but we don't really yet know that.
Some people are charging $3,000 for gene tests. How much do the gene tests you're talking about cost?
Well, I think that the cost of gene tests vary quite a lot. In the case of a gene test that requires sequencing of the gene, that can be arduous and expensive. In the case of clopidogrel, they're testing just for a single variation, and therefore that genetic test is much less expensive to do. The cost, of course, varies by which company and what country you're in, but is certainly not nearly as expensive as a test that requires sequencing.
A lot of the alternate medications to clopidogrel belong to the same family. So how would they work any better than clopidogrel?
And you're right, they work similarly to clopidogrel, but they do not require CYP2C19 for activation.
Are you finding genetic markers in people that predict their response to statins, to cholesterol-lowering drugs?
That's a very active area of pharmacogenomics research, and just like most drugs, statins have a lot of variation in response. There are some people who are more prone to adverse effects from statins.
And what's the likelihood that there'll be gene tests to see whether or not your statin's the right drug for you?
Well, I think that for one thing, there have been some published literature that there are certain genetic variants that puts one at increased risk for the muscle problems that are sometimes associated with statins. And if that information can be replicated in other populations, that might be a very effective genetic test in order to decrease risk of complications of statins.
You're also interested in diabetes. Does this apply to diabetes drugs too?
Again, there are some discoveries that seem to be holding up with regard to response to treatment. In particular, there are some variations that will increase the probability of response to sulfonylureas, and in other lines of research, metformin is also being worked on. Cancer pharmacogenomics is also coming around, where now genetic variants are being discovered that predict responsiveness to, for example, tamoxifen in breast cancer. And again, those genetic tests are not yet being applied widely, but in the not too distant horizon, I think they probably will.